would like now to introduce Dr. Prof. Farjah Alqahtani. Prof. Farjah is the director of the lymphoma program at King Saud University, King Saud Medical City Hospital, and she's a professor, faculty of medicine, Department of Medicine Oncology Center. She's a senior scientist at King Saud University, clinical trial graduate at Harvard Medical School. She's a clinical research focus, and her clinical research focus in cancer, lymphoproliferative disease, venous thromboembolic disease, PNH, and SCD, including screening, prevention, and management. She's been invited speaker at international and local conference, and she's going to tell us about readiness, treatment success, biomarker, and patient-centered outcome in PNH.
Assalamu alaikum. Dr. Hazza thought his lecture is more challenging. My lecture is challenged to finish in 5 minutes. I will try to do that. So since morning, we heard a lot about the economic burden of the disease and the burden and the challenging of having drugs and which-based drug for those patients. Yet no one mentioned about the patient experience and how successful and the outcome of those patients, especially as mentioned earlier, those patients will need vaccinations, they will have recurrent infection, they need to be on antibiotic prophylaxis for a long time. So how is about the perspective of those patients? They have to come weekly, then every 2 weeks, then every 8 weeks to receive these medications, how they maintain their life. So we will be talking about those patients. The good news, in the last 12 months, we had heard a lot from perspective of the patient treatment and management, as we heard from Dr. Rajhi earlier. And the more we understand about the patient genetic mutations, the more we understand how to fight the disease and how evolving treatment affecting the outcome of those patients. So we are optimistic from treatment point. And I will just emphasize very quick, this is ultra rare and ambiguous disease. Patient will be misdiagnosed or not diagnosed, as mentioned earlier, for years, sometimes it's 7 years, because it has similar symptoms with other disease. They will present hemolysis, thrombosis, cytopenia, and it will take longer time to have those patients to be diagnosed and thought. Maybe in our tertiary surface, we will be early to diagnose PNH and always sits in the back of our mind. But in the peripheral and the simple hospital, would they thought about PNH or not? So it's very challenging. We have that treatment available for treatment for classical PNH, already mentioned with Dr. Rajhi. We have treatment of PNH in the context of there is any bone marrow disorder and treatment of subclinical. So there is unmet needs for the anemia because, as we see earlier, those patients, they presented with hemolysis and anemia and transfusion requirement. And the most important is the health-related quality. We have those patients who is 33, as mentioned earlier. Those patients are pregnant and they need to take care of their kids. So we have a younger populations, and we need to discuss the quality of life of those patients having medication every 2 weeks, 1 week, antibiotic, and the vaccination. So we need to address these issues. We know from previous, and which mentioned since earlier, hemoglobin are not normalized on those patients. Still, they will have suboptimal treatment, and they will require transfusion. So, and I try to look for this two study, and the burden, looking to the burden of illness in patients with PNH. What's their perspective on those patients? We have one from US and one from the Europe, and it was from France, UK, and Germany. Both of them, it was survey, and they question the patient, and they look at certain parameter, the requirement from blood transfusions, the level of hemoglobin. In the Europe, they look at the effect of LDH of improving or not. So if you look here, the first two, it's from the US, I can't point, and the rest are from Europe. And there is improvement in hemoglobin, but still they maintain to be less than 12. And the other one, majority is less than 10. If we look at transfusion reaction, and they compare eculizumab and riflumizumab and this medication, and still 70% of patients treated with the complement inhibitors, still they will have a transfusion, and the level of hemoglobin will not fail to normalize in 6 to 12 months. So still, they will have the fatigue symptoms, and they will have required transfusion. This is the Italian experience. They defined the transfusion requirement as independent if they were able to be maintained above 8 and less than 11. And the optimal hematological response transfusion will be independent if they can achieve it more than 11. And as we can see, the number is very rare at 36. Transfusion dependent, we have more than 50% and minor responder. So anemia is really a concern for those patients, and it's the major disease problem. So still, we know they will require transfusion dependent. And as we can see, more than transfusion, this is the US and the European, still the number is very high to require transfusion. So for a transfusion dependent, we have to keep in mind in those patients, there will be struggle to provide the blood for them, antibodies, and it's really a major concern for transfusion requirement. So how about the last one, health-related quality and fatigue? So even with eculizumab and riflumizumab, still patients will experience fatigue. And fatigue is very important, a sign of those patients. And they distribute the questionnaires, and fatigue was the most frequently reported current of these PNH symptoms. As we can see, in eculizumab was very 88%, 74%, and riflumizumab in the US, and the European is still very high. And they use different questionnaire forms, global health status, physical function, and facet fatigue. All of them they reported. So we heard good news about BIG, and this is, we were optimistic because more respond to the hemoglobin improvement. So how about it? And this, they distributed this questionnaire for clinician and patient to report it. And the number is not that a lot, it's 61 patients. And they reported, the doctor will report the age, comorbidity, and the parameters, and the patient will be according to the facet fatigue form, he will report his symptoms. As we can see, there is improvement in the level of the hemoglobin, there is no doubt. And this hemoglobin maintain even above for 26 months. And the improvement was witnessed from the first month they started. There was increase in the hemoglobin level more than 2.5. And they maintain it. The most important is they maintain the level of hemoglobin, not like the other study, they lose maintaining hemoglobin. As clinical parameters, we notice LDH is decreasing, which is good sign, and also fatigue. If we look to the fatigue, the first one, they responded 11% severe fatigue. As the time passed, in more than 6 months, the severe fatigue disappeared, and they reported only mild to fair fatigue, which is excellent improvement. And the same thing with quality of life. As we can see initially, they reported overall population. As the time passes, improving and start to disappear the poor functional or quality of life as patient reported. And in the same study, those patients who have been shifted from eculizumab to BEG, and they reported the patient and the clinician outcome, there was improvement on patient side. Also, the clinician, they reported satisfaction with the treatment modality. So still, as we saw earlier, Dr. Rajhi mentioned a lot about the ongoing trial. If we combine the treatment, what will be the outcome? Still, we need hematological benefit. It's heterogeneous in those patients, and still the EVH mediated is still a concern. Follow-up of those drugs is very short. Ongoing hemolysis during C5 inhibition will persist into anemia and fatigue, and there is urgent need for a new medication, which hopefully after the clinical trial, we have the alpha trial, and update of these trials can help us. So collectively, these studies signal transformative era in the treatment of PNH. Although we think this is ultra rare and ambiguous presentation, but still, and I think the more awareness and could improve individualized treatment. Dr. Hazza mentioned at the end of the treatment that to sit with the patient and discuss with him the treatment. And we are looking for more friendly, patient-friendly treatment. Keep in mind our population are young and they need to continue with ordinary life, especially in a disease so far not curative, rather than to control the symptoms and improving the quality. So we need a treatment which is very friendly and improve a quality of life. The ultimate goal is to tailor the treatment. Dr. Hazza very nicely mentioned, we sit with the patient, we discuss with him, and hopefully we have more treatment which can be tablets and friendly, less antibiotic needed vaccination. And this is the conclusion of my lecture. Thank you.
Very efficient in time. Thank you very much, Dr. Farjah. So now it is the break time and lunch time, and we are going back 1:15 exactly, inshallah. Thank you very much.